Everybody, we've got another heart today. This is specimen 1011 in our collection. The heart would have sat roughly in the chest like this, anterior surface coming towards the screen, the inferior surface towards the turntable, posterior surface towards the back here, superior head up here, inferior legs down here, left over here, right over here. So let's start off as we always do, which is by finding what appears to be the morphologic right atrium, by identifying what appears to be the right atrial appendage. And the right atrial appendage appears to be here. We find an appendage that's broad-based, triangular, or pyramidal in shape. So we'll go ahead and open up the heart there. And when we do that, we do find that there's pectinate muscles that spill outside the confines of the appendage, consistent with the morphologic right atrium. We also find the oval fossa here. We can find that the oval fossa is in fact intact. There isn't an intraatrial communication in the oval fossa. And then we also find the coronary sinus, which is right here. And we can also see that the Bayesian valve here, which appears to be fenestrated. Then we also find the tendon of Todaro, which is right here. And the tendon of Todaro and the coronary sinus are two of the three components of the triangle of Koch. The third component being the septal leaflet of the tricuspid valve. And this triangle is important because at its apex is where we expect to find the atrioventricular node. So here's the coronary sinus, here's the tendon of Todaro, here's what we think is the septal leaflet of the tricuspid valve, and here would be the apex of this triangle. So here's where we would expect to find the atrioventricular or AV node. Then we come to the right atrioventricular junction. We do find a right atrioventricular valve that appears to have three leaflets. Here's an anterior leaflet, here's a septal leaflet, and here is an inferior leaflet. So three leaflets. One of the leaflets does have direct septal connections consistent with a morphologic tricuspid valve. When we look at the ventricle that it's opening up into, there are coarse trabeculations, and there is a septomarginal trabeculation when we look here in the outflow tract. So here is the septomarginal trabeculation, aka the moderator band. As we look across this ventricle, we don't find any ventricular septal defects here in the inlet or in the septum here or in the outlet. Then we get to our first semilunar valve. This semilunar valve does have three leaflets, 1, 2, 3. And there are three sinuses as well. There are no coronary arteries that appear to be arising from any of these sinuses, all consistent with a morphologic pulmonary valve. Also important to note that the pulmonary valve is supported entirely by muscle. There is no fibrous continuity with the pulmonary valve in this heart with any other of the valves. And additionally, just to note that there isn't a true annulus. The oval or round annulus that we kind of echocardiographically create isn't really existent in the semilunar valve. That's not to say that the construct isn't helpful for surgical planning or interventions, but you can see that the annulus is truly crown-shaped and not truly oval or round in shape. Here is the pulmonary trunk. It has been transected. So far on the right-hand side, nothing out of the ordinary. But let's flip this heart to its back. Here's the posterior surface. Here is the left atrial appendage. Why don't we go ahead and open up this atrium here. Here we find a smooth-walled atrium consistent with a morphologic left atrium. Here is the orifice to the left atrial appendage. And here's the appendage itself. And once again, we find that the atrial septum, in fact, is intact. But now when we come to this left atrioventricular valve, we do find that this valve is highly abnormal. Now I want to point out that this here, this slit or cut here, has been made once the heart was removed. And when we look down at this mitral valve here, we find that this is a highly abnormal mitral valve. And in fact, here is the posterior leaflet, here's the anterior leaflet, and its orifice is actually this little slit right here. So in fact, we're dealing with a heart that had mitral stenosis, and this in fact is the effective mitral orifice here. So once again, here is the anterior and the posterior mitral valve leaflets, and this right here is where they would have coapted. So a very small effective orifice of this mitral valve. So in fact, a heart with mitral stenosis, then we look at the ventricle that this leads into, and there are fine crisscross trabeculations consistent with the morphologic left ventricle. There are no septal connections from the anterior leaflet of this mitral valve to the ventricular septum, consistent with a morphologic mitral valve. And here we can see one of the papillary muscles, and here is that anterior leaflet of the mitral valve once again. We can see that there is now a second semilunar valve. This valve is not completely supported by muscle. There is fibrous continuity, a part of this semilunar valve with this anterior leaflet of this mitral valve here. We do see coronary arteries arising from the sinuses of this valve, consistent with a morphologic aortic valve. And then here is the ascending aorta, which would then give off the transverse arch and then the descending aorta. So a heart with mitral stenosis, and we'll take a look at this mitral valve once again. And now we'll try to look at it kind of down the left atrium. And you can see there's a very tiny effective orifice of this mitral valve. I'm sorry, it's hard to demonstrate it, but let me go back to the valve itself. Here is the anterior leaflet, here's the posterior leaflet, and this would have been the effective orifice of this mitral valve. So here we've got a heart that has usual atrial arrangement, concordant atrioventricular connections, right-handed ventricular topology, an intact ventricular septum, and concordant ventricular arterial connections with a stenotic mitral valve.